Hello everyone, a very good evening, and I am honored to welcome all of you to our ninth session of Tuesdays with Teachers, inspired by Tuesdays with Maury, which is one of the major learning lessons which we've all learned throughout these sessions as well. It's my honor indeed, not just because these sessions have been so well received and covered so many relevant topics, right from primary amenorrhea, second stage, to now going from the embryo last week to the fetus this week. But it's also an honor because of the people who are associated with this. Our honored Dr. Mitra Saxena, who is the convener for this program. She is very special to me. I have known her as family first, even before I have known her as an obstetrician. And it has been an honor to see her work, to learn from it, to hear of her experiences across two countries and practicing for all the decades that she has. More than anything else, it is always the energy and the ideas that she brings to any room, which makes every program that she's associated with seem so vibrant. And of course, our honored speaker for today, Dr. Prathima Radhakrishnan, who is not just my mentor and teacher, but a person who is also very dear to me. I have learned not just fetal medicine from her, but also so much about ethics and empathy that we can offer our patients, and without any unflinching compromise in the quality of care, no matter which corner of the world we practice in. And anyone who's had the honor of being in BFMC, being in the procedure room and seeing her perform these procedures, knows how effortless she makes it seem. And only once you start practicing yourself, do you realize what kind of a challenge that brings. Our topic for today now, there was a lot of to and fro that we had over what all that we should speak about. And we've brought the scope to soft markers on scan. How can the obstetrician help? What are the things we see on the scan most commonly, and how do we approach it? And I'm sure, as always happens with ma'am, no matter on which stage she speaks, we will learn a lot of key principles that can be applied to multiple scenarios, apart from, of course, the specifics of the topic. And I absolutely look forward to her talk. I would now invite Dr. Mitra to say a few words. And in the meantime, I will share my lesson from Maury this time. Yeah.
Thank you, Kirti. Thank you both for being so sweet and kind and loving to acknowledge my presence. And I am indeed honored with Dr. Prathima and her protege. You know, Kirti, I like you, I love you, but I admire you and respect you for the clarity of thought that you have practiced in your fetal medicine. And I think, Dr. Prathima, that is a very big compliment to you. If your students kind of clone you, your job is done. So, Kirti, I will be very happy. We'll spend 1 minute showing Dr. Prathima's CV. Well, if our audience doesn't know, let me tell you that I have a special fondness for people who get all the knowledge that there is in the West, but they come back and they serve their country. And what I know a little bit about Dr. Prathima is she's one of those that she got everything that she could, and now she's here to spread the good word, to spread positivity. I always like to say that people like you are like an oasis in the desert of, desperation. So you bring a lot of hope and good mentorship to our country in fetal medicine, and I'm very honored. Two things I would like to tell. After speaking about Dr. Prathima, I also want to introduce Kirti. She's a brilliant girl. She has brought a lot of, what do you say, newness to Rewari. And she's two things about one about Dr. Prathima and Dr. Kirti, which is not written in their CV. Dr. Prathima is very melodious. She's a very good singer, and Kirti is a very good dancer. This is the personal inside information I wanted to share with our, guests, our delegates today. And then definitely, I'm a very greedy person and asked lots and lots of questions. So I think, Kirti, we should not spend more time. If you can flash Dr. Prathima's CV, it'll be good. Otherwise, we'll just, allow her to take on the session.
I'm sharing ma'am's CV right now. Can you see
I
it?
can't see it actually. It's not there.
Oh, it shows you are screen sharing.
No, beta, only that is coming.
Is it? Oh,
Otherwise, I would have spoken from her CV.
oh God.
Never
Okay.
mind.
Showing on
Okay.
my screen. Can you see it now?
Yeah.
Okay.
Friends, you can see that she has many firsts to herself and she's extremely qualified and very humble. And then, she gives, I am fortunate to be on her Facebook friend list. So when she gives those 5 minute snippets, so I was hearing isolated oligohydramnios and I was so enamored and I knew about her. But that's the time the thought came to me that Mitra, for your Tuesday session, here goes the teacher. And I gave her a call and she said, of course, anytime. So, Kirti, that was a little bit of Bhumika, setting the context. Now we already have 184 people and no more time to talk about these little things. We'll talk later. Over to you, Dr. Prathima. Please, the floor is yours. And Kirti, from here on, you were in charge. Thanks so much. And I'm here all the time.
So I will stop share. Yeah.
Yeah.
Yeah, I've taken the share. Thank you very much, Kirti and Dr. Mitra, for the very kind words. I feel humbled, and yes, there is still lots and lots to do. As my professor, even this time when I met him in FMF, he said, okay, there is still a lot more to do. And I was quite shocked. I said, 22 years, and what more do you want me to do? And there goes. And he's, he's a great inspiration. And of course, a lot of my talk comes from that as well, right? So, sorry, just a minute. I'm just trying to minimize this. Okay. Okay, I suppose you can see my entire screen. So we will talk about soft markers, and the biggest challenge what we see is in the second trimester. And hopefully many of you would be aware that Professor Nicolaides is the one who is propagating the concept of inversion of pyramid of care. In the past, we used to see the patients very less frequently in the beginning of the pregnancy, and as the pregnancy advances, monitor them more closely towards the end, and therefore pick up the problems only after they have developed. Now, the concept of inversion of pyramid of care is exactly inverting the pyramid, where you primarily aim for prevention, which is better than cure, as we know. So you screen the patient in the first trimester and then triage the patient in the beginning itself, so that then what you monitor later on will be primarily the high risk pregnancies. So primarily screening and diagnosis is shifting to the first trimester, but we know, of course, the second trimester is still a very important scan, and I'll come to it with this prelude. So the primary aim of antenatal care is to reduce the mortality and morbidity associated with various conditions like anomalies, which could be structural, chromosomal, placental problems with placental insufficiency, preeclampsia, growth restriction, and of course, preterm delivery. And here the focus in this talk will be primarily on chromosomal, that is the aneuploidies. Now, it is important to understand what is an aneuploidy. Aneuploidy is abnormal number of chromosomes. We all know we have 23 pairs of chromosomes. One set comes from the father, one set comes from the mother. So 46 chromosomes. So any abnormal number in the chromosomes is what is known as aneuploidy. It could be excess chromosome, 47 chromosomes in trisomy 18, 21, 13, etc. Triploidy will have 3 sets of chromosomes, and the tetraploidy will have 4 sets of chromosome, etc. When it comes to ploidy, the triploidy, so it's 3 sets. Okay. Now, the visualization of a chromosome picture is known as a karyogram. And of course, because of the prenatal testing, the last X and Y sets are hidden in the prenatal in the prenatal settings. Now, before we go into screening, we must understand what is diagnosis? Screening is not the same as diagnosis, okay? Diagnosis of chromosomal abnormalities is primarily by invasive procedures. CVS and amniocentesis are the primary invasive procedures, and the risk of miscarriage in experienced hands is not very different between the two. It's about 0.3%. In good, well-trained hands, of course, right? Now, the 0.3% is above the background miscarriage rate. Now, we know when we see a pregnancy in the first trimester before 16 weeks, the risk of miscarriage, irrespective whether you do anything or not, is about 1 to 2%. And after 16 weeks, the risk of miscarriage, spontaneous miscarriage, reduces. Now, the timing of when we do the CVS is up to 16 weeks, and therefore people have mistakenly calling it risk of CVS is higher than amnio. Actually, the procedure related risk is pretty much the same, except that when we are performing a CVS, the background risk for the mother is higher. And of course, we are performing the procedures in high risk pregnancies, which anyway have a higher background risk. Now, when obstetricians get these results, right, it's important to just look into the result as well, not just look into the green and red, highlighted fonts. So a normal karyotype will look something like this. There'll be 23 pairs of chromosome. It ends with 22, and then the sex chromosome is hidden, of course. So this is a normal karyotype, 2 of each. Then you have an abnormal karyotype. Now, this is typically chromosome abnormal. Most common abnormality, which is trisomy 21 Down syndrome. So you can see there are 3 chromosome number 21, 1, 2, 3, and everything else is 2. And majority of the Down syndrome are this trisomy 21. However, there will be about 3% of Down syndrome, which will be what we call as a translocation Downs. So if you can see here that chromosome number 21 is only 2 there. So then you would be wondering, why is this still called Down syndrome? Because here, this is a translocation down. If you look at the 1421, there is an extra 21 sitting on chromosome number 14. So there is the extra chromosome number 21. So there's 1, 2, and there is a third chromosome there. So this is translocation Down syndrome. So these features of Down syndrome, irrespective whether it is trisomy 21 or translocation, is exactly the same. Now, obviously, this is very important for the obstetricians to know, because the risk of recurrence, if it is a translocation Downs, will be different. And I will talk about that in a few slides, right? Now, why is it important to check the karyotype of a fetus that is showing some abnormalities, right? Because there is a risk of recurrence, because that's the next question the patients will ask. Why did this happen to my baby? And will it happen again? So the risk of recurrence, if it is just a free trisomy 21, is about 1%. And realistically, you do not need to check the parental karyotype. On the other hand, if it's a mosaic trisomy 21, which also has the same features of trisomy 21, or very similar or very close to features of trisomy 21, the risk of recurrence is almost nil. So you can be very reassuring to the couple. On the other hand, if it turns out that the fetus has a translocation involving chromosome now 21, depending where the translocation is kept, is it 1421 or 2121, and who is the carrier, whether the mother is a carrier or the father is a carrier. So you will notice that if you have a translocation Downs, you have to test the parents. Whereas if it's a free trisomy 21 or a mosaic trisomy 21, you do not need to check the parents at all, because they will be normal. So coming back to translocation, if the mother is a carrier or the father is a carrier, or both may not be carriers, it may just be a spontaneous mutation, but just by chance the baby has a translocation. The risk of recurrence if the mother is a carrier is about 12%, whereas the father is a carrier is 3%. And if both are not carriers, then the recurrence risk is the same as the baseline risk, which will, of course, be determined by the maternal age in the subsequent pregnancies. On the other hand, if it is trisomy translocation 2121, which and you find that either of the parents is a carrier, then that is not good news at all, because the recurrence risk is 100%. So now you understand why it is important to investigate these fetuses and understand what is the abnormality in this fetus. Now this, I'm giving an example of trisomy 21, but there is such examples in almost every chromosomal or genetic abnormality. Now, do we really need to do we really have Down syndrome in our country? Because majority of the women still are young when they get pregnant. Is this really true? It is not true. We have the highest number of deliveries across the world, and 500,000 children are born with congenital anomalies, Down syndrome, 21,000. This is a very old data, and I'm sure there will be more here, because now we have more pregnancies which are beyond 30-35 years, and people are doing all sorts of things to delaying the pregnancy. Okay, now therefore it is extremely important, and the other biggest challenge is that we do not have the resources to look after these children as well. So the important to screen for the disease, do offer prenatal diagnostic tests, and give parents the option. And of course, we have to always be aware of false positive results and false negative results, but a screening test, which is a low risk result, is vastly reassuring. And I think that is also a major chunk of our jobs. Now, coming to prenatal pre and post test counseling obviously should be easily understood. Complete information, informed choice, backed up with leaflets and videos will always be helpful. Now, before we embark into screening, embark into the markers, we need to understand what is screening, right? Screening means basically we are trying to identify apparently healthy, in an apparently healthy population, the women who are more likely to have a disease. Okay, so basically the test that you're going to put on the population is like a sieve, okay, like a filter. So you put the filter to this population, and then you assess the population. Some of them will stay on top of the sieve, many of them will be discharged. So these discharge are screen negatives, and these ones which have been on top of the sieve are the screen positives. Now, in the screen positive and screen negative population, in the entire population, of course, you will have few babies with chromosomal abnormalities. Let us see the blue people who are abnormal here. So when we put the sieve, some of the blues will stay up and some of the blues will stay down. So your test or your sieve has to be so strong that you will at least have majority of the blues on top of the sieve and very few going below the sieve, so that your false negatives, because that means they tested negative, but actually that person had the problem. Whereas here, all these will end up having further testing. These are the false positives who do not have the condition. So you have to minimize your false positives and increase your and reduce your false negative. In the context of prenatal screening, all the screen positives will end up having procedures, and therefore we must reduce the risk of miscarriage, because the less number of CVS you do, the less miscarriages you will have, obviously. Okay. Now, the aim of the screening is a balancing game where we want to improve the detection, so detect as many blue men as possible and reduce the risk of miscarriage by doing as less invasive procedures as possible. So that should be the goal of a screening test. Now, historically, there have been so many screening tests that have confirmed, have evolved over a period of time. And then finally, we have landed up with cell-free DNA testing in the last few years, which has taken over a lot of screening. But at the same time, we have a lot of dilemmas from that as well. Now, universal screening is the way to go ahead, and there is no debate on that whatsoever, right? Let us understand that as a mother gets older, the probability of having a baby with Down syndrome increases, but also as the gestational age, okay, I'll come back to the gestational age. So the risk of any trisomy for that matter, trisomy 18, 21, which is the commonest, trisomy 18 and 13 also go up. Now, obviously, trisomy 18 and 13 have a lot of structural abnormalities, and therefore it is not as high as trisomy 21. Now, in the first trimester, we have a whole lot of measurements looking at the CRL, looking at the nasal bone, nuchal translucency, tricuspid regurgitation, etc., etc. So these first trimester fetal measurements must be taken. And then, of course, serum biochemistry in the first trimester helps because the beta HCG tends to be elevated and PAPA tends to be lowered in pregnancies that are affected by trisomy 21. And of course, when you combine the scan and the blood test, that gives us the best, highest accuracy for detection of chromosomal abnormalities. Of course, the bloods should be performed in standard laboratories, and the scan should be performed by sonologists who are certified to assess it properly, or who are able to give you proper images. And as an obstetrician, you should know what an NT image looks like. It should look like only this and nothing else, right? Good magnification, good clarity, nice profile, look at the nuchal translucency and proper measurements. I don't think there should be any compromise in this whatsoever. Right? Now, when we combine the first trimester combined test and the second trimester markers, then our detection rate can improve further for all the common trisomies. Okay. Now, so just a word about cell-free DNA, because there are so much of cell-free DNA testing that is done post the first trimester, and it becomes very important that when you're looking at the second trimester markers, to interpret that in correlation with the same. Now, let us understand that cell-free DNA testing, or NIPT, whatever you call it, the Form F and Form G must be documented, because this is a test that has got a potential to detect the gender of the baby. So Form F and Form G must be documented for performing NIPT. And of course, the center should be registered for performing a test like that, even though it is just a blood test, and no people's homes are not registered center, for God's sake. I think obstetricians should be safe. Now, the cell-free DNA includes the maternal and fetal DNA and the placental DNA. And of course, when you have fetal fraction, that is also should be reported in all reports. When it is less than 4%, or when there is no results, you can have a lot of false negatives. So if you don't get a result on the cell-free DNA, don't keep repeating the test again and again, because that's waste of time and money. And you need to act upon it, because there could be some other problem, if not Down syndrome. Now, the detection rate for cell-free DNA is very good, of 98 to 99%, even for singleton and twins as well. Pretty good for trisomy 18, 13, but we are not looking at those anyway, because those ones pretty much will show us a lot of structural abnormalities on the scan itself. Okay. Now, before advocating a cell-free DNA test, it is absolutely mandatory that you have done a proper scan and checked and made sure that the baby looks normal. Understand, it takes 10 days to 2 weeks, and a positive or no call result will warrant an invasive test, a screen positive or no call. Okay. And if there are structural abnormalities, then I don't think it's the right test to do at all. You should only do a scan. Okay. Now, so it is not recommended, cell-free test. It is important to know, we cannot replace cell-free DNA testing, the first and second trimester scans, by cell-free DNA testing. It must not be done prior to a scan. First do a scan, check and make sure, because otherwise, it's unnecessary waste of money. Triplets and higher order, it is not validated as yet. If you have a structural anomaly or soft marker for other genetic syndromes, right? I will come to that and I'll show you that as well. Then I don't think that it should be done. If you have an NT which is more than 3.5, it is not the recommended test, because we know that when the NT goes up more than 9.4, 9.5, there is a high probability of finding a genetic syndrome as well. So your cell-free DNA test will not suffice. And of course, if you have a really high risk report on your combined test, that is more than 1 in 100, some units go more than 1 in 10, they don't recommend NIPT, and invasive testing is the first order, because even with abnormal biochemistry, we can have some atypical chromosomal abnormalities. And of course, cell-free DNA testing cannot be done for genetic syndrome. So if you're suspicious, or if the woman is going to undergo invasive test for a single gene disorder or a inborn error of metabolism, don't waste their money on NIPT. I think we should absolutely know when not to do NIPT. Majority of the people are just doing NIPT left, right, and center. I think this has to stop. This has to stop if we really want to benefit our women, because you have to think before offering an NIPT. Coming to the post-test follow-up, screen negative is good, reassuring. Screen positive, I said, should have invasive, and no call should have a repeat test. Now coming to the soft markers, because it's very important that this background of the first trimester and the serum screening, that is NIPT. NIPT is a blood test, is a serum screening test. It's not a diagnostic test. So with that in the background, let us see how we can assess in the second trimester, because many of the women have had a first trimester scan and have had NIPT by the time they come for the second trimester scan. And now how do we kind of interpret these soft markers? Okay, now prenatal screening for aneuploidies, we always have a priori risk. That is a priori risk, that is risk has already been determined. Now, if she's had a good screening, then you will take either her first trimester screening or combine if she's had a cell-free DNA testing or a biochemical screening. And if she has had no screening, then you would take only the age and the history, okay? Or if she's had a poorly performed first trimester screen, where you have no idea which lab the blood tests are done, it is reported poorly, the NT image is bad, so that is as good as no screening. Bad screening is as good as no screening. Either you screen properly or there is no screening at all, right? Now you do a scan, and you do the second trimester scan, what you call as a genetic sonogram. Also, it is also known as genetic sonogram, because you're looking at all the soft markers, and then you adjust the risk. So you start off with a priori risk, and then you adjust the risk based upon what you find. Of course, whenever you're looking at soft markers in the first trimester, the first thing you should do, apart from ask the age and the history, is go back to the first trimester scan, look at the image of the nuchal translucency. Have they measured it properly? Does the nuchal translucency look good? Nasal bone is present. The first trimester markers are there. There's no structural abnormalities. The dating is correct. Look at whether they've had any serum markers, whether they've had double marker, quadruple marker. Go back and look into the history. It'll hardly take you 2-3 minutes. And once you get used to it, it'll just take you less than a minute. Okay. Then you assess the second trimester markers. Okay. So second trimester quadruple screening. Has she had any screening already by the time she's come to me? Whether she's had a cell-free DNA test, and of course, you look at the biochemical screening, look at the genetic sonogram, and of course, these 10 are the major markers. Well, not markers, soft markers, not major markers, most commonly reported markers, I would say. And some of them are very important. Some of them are easy to visualize, and therefore they still continue to be in the list, because you don't need to have the best of machines to see these markers, okay? And anybody pretty much can see these markers. Now, the markers are majority of the times normal variation in the fetal anatomy. There is usually a small to moderate risk, especially if they are isolated. Most of them are transient. And as the pregnancy advances, they resolve, and there is no major clinical sequelae if they are seen on their own. Okay. However, the presence will increase the probability. Now, there are some of them which are measurement based, some of them just you report as present or absent. Okay. And majority of the fetuses with markers will actually turn out to be normal. And this is because majority of the fetuses are normal. This is what I tell parents. The first opening statement I have to almost all my parents when they have markers is, very likely your baby is normal. Now, in that 2 to 3% chance that the baby could have an abnormal, then listen to me further on, because you need doctors to pick up abnormalities. You don't need a doctor to tell you everything is normal, because, you can sit at home and everything will be normal. That's how my grandmother had kids. But my grandmother accepted certain babies with abnormalities. You are sitting in front of me because you are not ready to have even one child with an abnormality. right? So that's, that needs to be understood. And why? The current generation is absolutely right that wanting to have completely normal babies, and it is our job to make sure that their path is made easier. So now look at the soft markers in the second trimester, all right? Okay, so the first and the most common soft marker, which is a bug to most of the obstetricians, I'm sure, is this little white dot in the muscle wall of the heart. And it just doesn't seem to go out of literature. Every single time it keeps coming back. Why? Because you can see that it is the most easiest thing to visualize on the scan, right? It's a white dot. It just shows on your face. So you don't need to have the best scanning machines to be able to see the EIF. So if you see an EIF, respect it. But we cannot ignore it, but we have to respect it. It may be present in one, it may be present in the right side, it may be present in both. It can be in, it can be present in number, maybe 2, 3, 4 also can be present. Now, it is usually not associated with any cardiac abnormalities and an isolated EIF. Now, it is my job to prove that it is isolated. An isolated EIF will be a normal variant, especially if the mother has already had a cell-free DNA test done, right? Now, about 28% can have aneuploidies, whereas 30%, and this is just based only on the EIF. Okay. Now, importantly, we have to differentiate the EIF from myocardial calcification. So in the EIF, as you can see, it is clearly within the papillary muscle. So when you have bright white spots on the muscle wall of the heart, that is different. That is endocarditis. That is a different condition altogether. So it is very important to see the location of the EIF. Now, if they've had no I don't know why this is transiting before me. If there is no previous screening, and it's only an EIF, that means you have done a cell-free DNA test and second trimester quad can suffice, and it is an isolated EIF. If she's had a previous low-risk FTS, or if she's already had a cell-free DNA testing, then ideally there is no need for further evaluation. And very rarely you may require invasive testing because there are obsessive parents. There are parents and they've got their own reasons to believe that they want everything to be absolutely perfect. And I think occasionally I have done an invasive test primarily for reassurance. Right. And of course, provided the couple understand and everything is documented, because it is not that EIF cannot have Down syndrome. Of course, these babies can also have Down syndrome, especially when you have had no previous screening, or a very heterogeneous kind of screening that happens in our country, unfortunately, because screening is not universal still, right? Now, next is the choroid plexuses, which are little cysts within the choroid plexus of the fetal brain. Now, these are obviously not brain anomalies, and they can be associated with trisomy 18. These are not markers for trisomy 21. These are markers for trisomy 18. And the good thing about trisomy 18 is there are a lot of structural abnormalities associated with trisomy 18. So if you check and make sure that the baby is normally grown and that there are no structural abnormalities at all, then if the couple are still anxious, you can still offer them a cell-free DNA or a second trimester quad. But if they've had a good first trimester screening or even a cell-free DNA for that matter, no further evaluation is required. And very rarely you may require invasive testing. So it is very important to tell them that, hey, look, this is not a brain abnormality. It is seen in the glands which is inside the brain. And of course, when we see that, we have to make sure that there is no other abnormalities, and particularly the baby's growth is good. Coming to single umbilical artery. Now, single umbilical artery is also quite frequently seen, and it is seen at the level of the bladder, and it's detected on color flow, of course. Aneuploidies are not very common at all with isolated. Again, when I say isolated, single umbilical artery, irrespective of previous screening, there is realistically no further evaluation, no further testing that needs to be done, apart from the fact that you make sure that all her previous screens are normal, there is no associated abnormalities, and no fetal growth restriction. So you will follow them up for, fetal growth with growth scans. And there is also very questionable association with stillbirth. So there is really nothing to panic if you have had a really good scan with a single umbilical artery. Now, coming to urinary tract dilatation, or a UPD or RPD, whatever you call it. Now, this is one of the most frequently seen anomalies or markers in the second and in the third trimester. And when it is less than, 7 millimeters, that is called mild RPD, and it's very likely a physiological and transient event. It's likely to resolve, but they need follow-up for urological problems. Now look back again, previous screening has been done. If she's had a cell-free DNA test or a second trimester quad, then of course a good first trimester screen, there is no further evaluation that is required. And very occasionally they may require invasive testing, but these babies will require a follow-up, and I will talk about it in a bit. Now, next thing is short long bones, which are very slightly short, not hugely short, not below the third centile. It's just below the fifth centile, and the humerus and the femur. And again, go back and look for other markers. There is no screening. If it is isolated, you can get away with cell-free DNA or a second trimester quad. But if there is good first trimester screener, already you have done a cell-free DNA, then I think the baby requires follow-up for growth, especially of the bones, and for skeletal issues, and nothing immediately. However, if the bones are very short or abnormal appearing bone with sometimes fractures or hypo mineralization, then there is a need for invasive testing, because then you're not looking at aneuploidies alone. You're actually looking for skeletal dysplasias. Right. So it is very important that when you look at the images, they should look as bright, like bright as a bone, like as I say. Okay. Now, the other thing is hyperechogenic bowel. Now, hyperechogenic bowel, I've reduced the gain completely and then compared the echogenicity of the bowel, which is almost as bright as the bone. And this is what I call as an echogenic bowel. Again, it's very important that the criteria is followed to label it as echogenic bowel. Look at previous screening. If there is no screening, you can do cell-free DNA or a second quad. If there is previous screening done, there is no further evaluation. But in these cases, we would probably consider invasive testing in certain circumstances, especially if there is consanguinity, etc. Because or if there is a history of possibility of infection, because these are markers for infections and cystic fibrosis. Of course, they will require follow-up for gastrointestinal pathology, because some of these can be associated with bowel obstruction as well in the third trimester. You will not see it in the second trimester, but you will see it in the third trimester, and of course intraamniotic bleeding as well. So you will require follow-up for the hyperechogenic bowel. Okay. Now, coming to nuchal fold, and this is an important marker. This is a continuum of the nuchal translucency in the second trimester. In the first trimester, we call it nuchal translucency. In the second trimester, we call it increased nuchal fold, NFT. So you can see it is cystic as well there. So it is measured in the axial plane where we measure the cerebellum, and it is outer to outer. And it is one of the most sensitive markers. Again, go back and look at screening tests, and if it is isolated, you need to give the patient all the options realistically, even if it is isolated, because there are certain other genetic syndromes that can be associated with increased nuchal fold. And again, you can see that very clearly. The nuchal fold is increased, and when I'm tapping the maternal abdomen, it is wobbly as well. So it is important to elicit these signs very, very clearly, right? Then only you're sure about the marker. Now, if the first trimester screen is negative, then you may cell-free or invasive. It is important to discuss these patients. So in these particular cases, we would consider doing an invasive, irrespective of previous screening, because you need to look out for possibility of genetic syndromes and CNV. That is now, because chromosomal microarray has become so widespread and popular, we need to look out for rarer symptoms. And of course, the other very important condition is Noonan's syndrome. Noonan's syndrome also has mild to moderate degree of mental challenges, and it will not be picked up on a routine karyotype. So you have to specifically ask for a Noonan panel separately. And so these things, I think your fetal medicine specialist should be aware while performing the invasive test, what tests to be requested on the sample as well. Coming to absent or hyperplastic nasal bone, I think this is becoming more and more popular, has become more popular. It is, of course, an extremely good marker. And what we're looking at is less than 5th centile. And we described the nomograms for the nasal bone way back, more than 10, 15 years ago, and it is widely available online on the perinatology calculator. So please go back and check the and use the perinatology calculator to see whether the nasal bone that has been, even today I had 2 babies which were referred with hyperplastic nasal bone, but both the nasal bones were normal, and they were 4.6 and something like that, which was completely normal for an Indian baby. Okay, so the perinatology calculator can calculate for different ethnicities as well, because we know that there is an ethnic variation. So of course, if they've had no previous screening or self-negative testing, previous screening, you would still consider invasive testing, because this is a very strong marker for chromosomal abnormality, particularly Down's syndrome. Okay. Now, evaluation, when you have a hyperplastic or an absent nasal bone, it is very important to look for other associated structural abnormalities. Primarily look for markers for aneuploidies, for craniofacial abnormalities, particularly mid-facial hyperplasia, etc. And we would offer them invasive testing, which would include FISH for major chromosomes and chromosomal microarray, and store the DNA if it is isolated, right? Of course, if there are multiple, then you would discuss with the geneticist to see whether you need to do an exome. I don't do exome as the first line. I still go with array and then decide, keep the DNA. And if there are any more markers or anything else that comes up later, we can always work on the stored DNA. So if it is isolated, very likely it's a normal variant. However, it is extremely important to look for associated anomalies, look for consanguinity, because some genetic syndromes can have an absent nasal bone as well, and specific family history of any specific conditions, any other specific conditions. Okay. Now, the other very important marker is mild to moderate degree of ventriculomegaly. Now, obviously, this is something that concerns many people, that there is a fluid in the brain and is this going to become bad, and etc., etc. Now, mild ventriculomegaly, even up to 13, 14 millimeters of ventriculomegaly, up to 15 millimeters is mild ventriculomegaly. Many of them will resolve. And if once you've made sure that there are no markers, they are likely to be benign as well. However, if it is progressive, then you have cause to worry. So if you look for associated anomalies, you look for associated markers, and look for, if 1 in 3 will have any other problem. So the fluid, the black space is very easy to detect on the scan, right? Now, genetic testing must be offered to this couple. Usually again, as I said, I always start with FISH for major chromosomes. I look for infection, particularly CMV in toxoplasmosis, and of course, do a chromosomal array, and I store DNA, because if there are any other anomalies that come later on in the pregnancy, particularly evolving brain anomalies, then I would consider doing further genetic testing and even a neurosonogram, and if required, MRI based on the neurosonogram. Follow-up for this mild ventriculomegaly is extremely, extremely important. Okay. Now, the last soft marker is an aberrant right subclavian artery. An aberrant right subclavian artery is seen on color on cardiac screening, and it is very clearly visualized on the scan. However, not very many units do look for ARSA, but it is something that has become very popular, at least in the fetal medicine units. I believe that people should look out for ARSA, because then you are completing your genetic sonogram, right? Now, fetuses with Down syndrome the fetuses with URSA have a 4 times increased likelihood of having Down syndrome, and therefore important to look out for previous screening, look out for the cell-free DNA testing, and I would add on to look at the thymic thoracic ratio, because we know that there is thymic hypoplasia when it comes to DiGeorge syndrome, which is the 22q11 microdeletion, which is one of the commonest genetic abnormalities, and therefore you need to one of the common genetic abnormalities, and it is not routinely screened for, which has got huge implications for the family. So if you find an URSA, I think it's very important to consider invasive testing, talk to the parents and discuss with them, because you don't want any of the other things. So here you can see there is a 4-chamber view, LVOT, RVOT, and then of course you can see a normal right subclavian artery there, whereas here you can see that there is a aberrant right subclavian artery which goes behind the trachea, and in this case you can see that it is going in front of the trachea, right? So that's a normal right subclavian, and that's an aberrant right subclavian artery. Okay. Now, structural abnormalities. You're not finding markers, but you're looking at structural abnormalities in the second trimester. So if you have an isolated anomaly, just single anomaly, there is still a 20% chance, up to 20% chance that you can find a chromosomal abnormality. That means 1 in 5 fetuses with the structural abnormality can have a chromosomal abnormality. If you have multiple abnormalities, add a further 10%, right? And now as the pregnancy advances, we know fetuses with structural abnormalities and all, so fetuses with chromosomal abnormalities have an in utero lethality, terminations, etc., etc. And still in the live bonds, there is a 0.5 to 0.7% chance of having an aneuploidy. Now, when you have a low-risk cell-free DNA with a structural abnormality, right, that is very, very, falsely reassuring. So you need to be aware that when you have a structural abnormality, you cannot depend on the cell-free DNA. Cell-free DNA testing is a test which was largely devised for Down syndrome. It works extremely well with Down syndrome. But when we have a structural abnormality, we are not looking only at Down syndrome. We're looking at all the other things as well. And therefore, if you have a structural abnormality, irrespective of whether it is 1, 2, or multiple, even for a solitary structural abnormality, it is absolutely mandatory to do invasive testing, chromosomal array, and store some DNA. The other important is early growth restriction. Now, early growth restriction is defined as estimated fetal weight or abdominal circumference less than 10th centile in the second trimester at the anomaly scan. You have corrected the dating looks fine, but the baby is is small, right? And many times you will have a normal uterine artery Doppler also. Now, there is a 20% chance that you can have an aneuploidy or a genetic abnormality, and therefore you would suggest doing a chromosomal microarray. Of course, if there are associated findings, then the risk is significantly higher. Like if it is isolated, the risk is about 5%. If there is further abnormalities, it doubles up with structural abnormality. And trisomy 21, although fetal growth restriction is seen in about 30% of babies with Down syndrome, but 50 and 90% in babies with trisomy 18 and trisomy 13. So it's extremely important when you have a small baby in the second trimester to do a detailed obstetric ultrasound, look, have a good genetic counseling, and consider diagnostic testing. Polyhydramnios in the absence of maternal diabetes can actually be a marker and can actually be an alarm, a clue that there is likely to be a genetic abnormality as well. Now, what about the abnormalities? Trisomy 21, only about 1/3 of them will have structural abnormalities. Majority of them will have only markers, right? So, and what is even worse, 30% will have no markers or no anomalies. So you can have a completely normal looking baby, completely escape detection if you don't do proper screening, and then end up with having Down syndrome. Whereas trisomy 18 and 13 can have a lot of structural defects, and majority of them will have early growth restriction and amniotic fluid abnormalities. Whereas triploidy can have structural defects and almost always will have severe early onset growth restriction and placental abnormality. So Down syndrome is the most elusive of all, and that is also the reason why we talk so much about Down syndrome. Now, let us come to another important aspect. How do we calculate the risks? How do we put all these things together, the first trimester screening, and then calculate the risk? Now, when we have to calculate the risk, we must remember that every mother has a risk. Okay, now risk is basically a probability. Okay, every mother has a risk or a probability, and as the mother gets older, the probability increases. And then we have a calculation of a risk factor. Now, whenever we have a soft or a minor marker, it is more common in normal babies, but it is more common in aneuploidies. But essentially, by sheer volumes, there are more normal babies than aneuploid fetuses. Okay, that's why majority of the babies with markers will have normal babies. Now, there are large, variations that has been reported. We must understand soft markers are not defects, and I've showed you all of them. They're not harmful for the fetus or the mother, and there is actually no major implications for the baby if things are looking fine. And based on the markers only, termination is not an option. It is absolutely unethical, in my opinion, and medical negligence, or rather fetal negligence, I would say, to terminate a pregnancy with a marker, because majority of these fetuses will be normal. Now, other very important aspect to understand is what is a likelihood ratio. A likelihood ratio is the presence of the marker in the abnormal population divided by presence of the marker in the normal population. And that's where we get our true positives and false positive rate. Okay. True positive, that is the marker in the abnormal population, divided by the false positive, that is the marker in the normal population. So the more frequently it is seen in an abnormal population, the higher will be the likelihood ratio. Okay. The numerator increases. Okay. So you have a positive likelihood ratio where the presence of a soft marker will increase the a priori risk, At the same time, if the soft marker is absent, which is known as the negative likelihood ratio, it will reduce the a priori risk. So presence of the marker increases, but for example, if I find an EIF, that will increase the risk, but if I don't find the EIF, that will reduce the risk. So that's how the markers work. And based upon this, the meta-analysis of, by Agathocleos, where we looked at all the markers, the meta-analysis that still is going very strong even after 12 years, likelihood ratio was calculated based on detection rate and the false positive. So if you find a marker, it will go up. And if you don't find any of these markers, the risk will go down. So essentially, you only need to remember this last column where EIF has got a likelihood ratio of 1, almost 1. Lateral cerebral ventricle, 4 times increased likelihood. Increased nuchal fold, almost 4 times. Echogenic bowel, 1.5 times. Mild renal pelvic dilatation, like the echogenic focus, 1. Short femur, short humerus, nothing major, probably less than 1. C, hypoplastic nasal bone, nearly 7 times the risk goes up. Okay. And if you find an ARSA, 4 times. So essentially, your lateral cerebral ventricle, your increased nuchal fold, your hypoplastic nasal bone or absent nasal bone, and ARSA are the major markers that you need to be looking out for in the second trimester. Particularly, that has to be ruled out, because when I say echogenic focus is the isolated marker, I have made sure that there is no ARSA, there is no hypoplastic nasal bone, there is no renal pelvises are normal, there's no echogenic bowel, no increased nuchal fold, and lateral ventricle are normal, no defect in the baby, and importantly, no fetal growth restriction. Then I can say this is isolated. Isolation is a diagnosis of exclusion. It cannot be say, I can see only this one, that means nothing else is present. No, I have to make sure nothing else is present. Then I say only this abnormality is present. Now, what is the accuracy of the risk calculation? If I don't see any markers, what can I do? Now, there are studies which have done in routine ultrasound clinics where they have reduced the risk for trisomy in the absence of markers. They've reduced the risk of trisomy in twofold. But these studies did not include the nasal bone, ARSA, or short femur, or the humerus. So as you see, nasal bone and ARSA are very important markers. And if you don't include them in your risk assessment, in your routine assessment of all the fetuses, then you can't reduce the risk as much as in specialized units where they have used nasal bone and ARSA, and they are able to reduce the risk at least 3 times in the absence of these markers. Now, let us take an example. Now, this is a 35-year-old primey, and in the genetic sonogram, there is only EIF that has been reported. Now, her likelihood ratio for EIF is 1. So now we have to calculate the risk of trisomy 21. Now, maternal age is 35. She's had no previous screening test, or she's had a poorly performed first trimester, which is not reliable. Now, according to her background risk, the background risk for trisomy 21 is about 1 in 250. Let's say 1 in 250. Okay. Now, we have to divide this 250 by the likelihood ratio of an isolated EIF, that is 250 divided by 1, which is 1 out of 250. So essentially, her age-related risk remains the same, or her a priori risk remains the same. So that is the likelihood ratio of 1. Okay. Now, just imagine if this 35-year-old woman has had a first trimester screening already, a good first trimester screening that has given her a risk of 1 in 2000. Now, the background risk for the second trimester marker becomes my first trimester screening. So first trimester, she had 1 in 2000. So now my a priori risk is 2000 divided by 1, which gives me 1 in 2000, right? So which is better? And what is the game changer here? The game changer was a first trimester screening, which was done well done. Okay, so that was really the game changer for this woman. Okay, now additional tests will depend upon what the mother wants. Now, this lady has come and she's got isolated choroid plexus cyst. And now we know that there is a risk for trisomy 18 because she's got isolated choroid plexus cyst. Now, what is very good is to check her serum screening as well. Now, we have a maternal age 35. She's had no previous screening test. Background risk for trisomy 400. Adjusted risk remains 1 in 400. Now, look at the blood test if she has it done. Now, we know with trisomy 18, there are a lot of structural abnormalities and fetal growth restriction that can be associated with strawberry-shaped head. Right from the head to the toe, there can be abnormalities. And if I do a good scan and there is no defects at all, right, in the absence of all the defects and a normal growth, then, and of course, if she's had any serum screening, look at the hormone markers as well. Do a good scan, detailed scan. If there are no defects, then it is very, very, very small, negligible risk. So maybe she does not require any further testing at all whatsoever. Now, what happens if you have more than one markers? That was an isolated marker. So you have multiple markers. We know that each soft marker has its own positive and negative likelihood ratio. The absence of the marker will reduce the risk. The presence of the marker will increase the risk. Now we have to multiply all the markers, positive and negative, with the a priori risk to give us an adjusted risk. If you have a computer, of course, the computer will do the job for you. If you have internet connection, go onto the internet and look out for the perinatology calculators and look out for the paper, and then you will be able to adjust the risk. And of course, if you have a software, nothing like it. And ideally speaking, whoever is reporting these markers, that means either your sonologist, your radiologist, ideally your fetal medicine specialist, they have to be telling you what is the risk here, rather than as an obstetrician, you are struggling. That's not up to you, because the person who has seen the fetus should be giving the report on the fetus when it comes to this. Now, what happens if you have a major abnormality? Now, of course, we have to consider the lethality of the anomaly, but we know that if there is a lethal anomaly, there is a recurrence risk. Now, for the likelihood ratio for major structural abnormalities is about 5, right? Which means whatever your a priori risk, that has gone up 5 times. And then you have non-lethal abnormalities. Then in non-lethal abnormalities, very likely you are going to continue the pregnancy. So all the more reason to make sure that there is no additional chromosomal abnormality in the fetus. We have to discuss the prognosis and, of course, what are the likely potential intrauterine and postnatal interventions that the baby will require. Okay. Now, just a quick recap, the 10 soft markers most commonly used, they're relatively common on findings. There are no structural abnormalities. And of course, they are indicators for increased possibility of aneuploidy, and you have to check the previous screening test. Extremely, extremely important. Look at the previous screening test, and of course, the effect of a second trimester screening, if you already have done a good first trimester screening, is pretty small, unless you have the 4 major markers, as I already mentioned, the nuchal edema, the hyperplastic nasal bone, the mild ventriculomegaly, and the URSA, the last 4 there. Okay. Now, counseling is really the key. We have to discuss all the options. Guidelines are only there to guide. There is no right or wrong answers to anything. It really depends upon what the parents want. And of course, as obstetricians, you have to document it all, because ultimately the responsibility and accountability comes to you. So essentially, we must understand, if the couple want a confirmatory answer, they say, look, doctor, I don't want this ifs and buts, give me 100% answer, then you really have no option but to give them a diagnostic test that's an invasive test. A cell-free DNA test for Down syndrome is 99%, right? 99% reassuring, but if it comes screen positive, or if it comes as no result, do not repeat NIPT. Please send them for an invasive test. When we do the first trimester, first trimester scan, combined test with the second trimester quad test and a detailed anomaly scan, putting all together. So first trimester combined, second trimester combined, it gives a 90 to 95% accuracy. And finally, if you do only the scan, only the genetic sonogram and no screening, then that has got only 50 to 70% accuracy as far as screening is concerned. Now, what about assessment of soft markers in a normal fetus? Look at previous first trimester screen, look at previous DNA testing, look at previous, look at that if they've had none at all. And very importantly, you need to look if that fetus needs to be evaluated for other disorders. Like, for example, if you have short long bones, you need to look out for skeletal. If you have got hyperechogenic bowel, you need to look out for growth restriction, etc. And mild ventriculomegaly for evolving brain anomalies. So you need to evaluate not only for chromosomal, but also for other things in certain conditions. Now, let us look at what happens if there is no previous screening, nothing at all, or a poorly performed first trimester screening, and you have 2 or more markers, right? Now, of course, we would discuss with them diagnostic testing versus CNA, cell-free DNA, or no further evaluation. These are the 3 main options. Now, if she says that, look, I don't want anything further, I don't want any further evaluation, leave me alone. So then just said, okay, we'll assess the baby after it's born and do postnatal testing if indicated. Now, if the patient prefers a non-invasive test, you do a cell-free DNA test. If it is negative, then go ahead with a postnatal evaluation. If it is positive, then you must do a invasive test. Now, that could be abnormal or normal. Of course, if it is abnormal, you discuss the implications. If it's normal, it is routine care. Now, if the patient accepts an invasive test, then amniocentesis must be done. Fish for major chromosomes. If it's abnormal fish, you go ahead with karyotyping. And if that is abnormal, of course, further thing. If it is normal fish, you go ahead with microarray. And if that is normal, then of course, routine postnatal care. So basically for 2 or more markers, it's ideally best to do an invasive test, because that is much, much more informative than cell-free DNA test. Or of course, if the patient declines, they decline. We have to respect their this thing. So just a word of caution, if they have not had any previous screening and they decline invasive test, maybe, but you must inform them that if a cell-free DNA test comes back as high risk, or if it doesn't give us a result, then also it will be an indication to do an invasive testing. Okay, you should ensure that they are interested in further aneuploidy evaluation. And of course, it is a single most sensitive test for the common aneuploidies, that is the 3 main. So if it is screen negative, it's reassuring but not exclusive. If it's screen positive, or if there is no result, which can happen in 1%, you need to do an amniocentesis to confirm for chromosomal abnormalities or atypical chromosomal abnormalities. Now, if they've had a previous first trimester screening or a negative second trimester quad test, if these are isolated, EIF, SUA, CPC, UTD, short long bones, we can counsel and reassure them. If they've had a thickened nuchal fold or a hypoplastic nasal bone or mild ventriculomegaly, they do require further genetic counseling. So also ARSA and possibly HEB as well, because there is an association known with cystic fibrosis. So if there are more than 2 soft markers, you offer them genetic counseling, offer diagnostic testing. If they decline, of course, you can offer them cell-free DNA, but tell them that even doing cell-free DNA testing we can lead to sometimes doing an invasive testing later on. But if they accept it, then you do the invasive test there as well. Now, a negative cell-free DNA test is quite reassuring, even if the markers are isolated. But look out for the false negative cell-free DNA, because if you find structural abnormalities or any other additional problems, then you cannot depend on your cell-free DNA test. So if there are more than 2 soft markers, if they decline again, the same thing. Okay, so also remember, majority of the soft markers resolve by 3rd trimester, and they do not recommend performing postnatal genetic evaluation unless, of course, it is clinically indicated. Now, if there is, I think I've already said this, detailed scan and genetic sonogram. So I will stop here because I realize that I have taken up almost an hour. So we can take questions. I have put some cases together. If you want me, I mean, I'm flexible. I can do however you think.
I
Dr.
think it's been
Prathima,
very. Let's go ahead
chat
with
box
the
is full of questions.
Okay.
So I think we can also do it this way, Mitra ma'am. What do you say? We'll do a few questions and then go for the
I
cases
think
if
you take the
permit.
cases. So
Okay.
all the questions would get solved.
I think
Kirti, you can sum them up, and
yes.
then we can put the random questions.
So let's
If there are.
do the cases first, or do you want to go straight to the questions?
I
good.
think, Dr. Prathima, if you have cases,
Let's
you
do
should
the
share
cases
that.
first, ma'am. That will be
I mean,
interesting.
I've just got a few cases, that's all. I will just
That
run
will be
through
good.
them if you want quickly. Okay.
Yes, ma'am. Let's go for it.
Can you see my screen well?
Yeah.
Okay, fine. Okay. So I've just put a few cases that from our own this thing. So this is a fetus which had an increased nuchal translucency. You can see that very clearly. So obviously the background risk, she's a young 27-year-old. The background risk 1 in 1,000 became 1 in 160. So she was basically the 4 things. You know, remember there are only really there are only 4 options. There are not multiple options. You either offer them a 100% diagnostic test, a 99%, a 95%, or a, well, termination is not an offer, but yeah, I mean, if there is an abnormality, then yes. So we give them these 4 options. In this situation, the couple opted to have an invasive test. Invasive testing was done. CVS was done. Karyotype was normal. With an increased NT, we know that we need to check for heart abnormalities also. And this had a normal delivery. It's 3.3 nuchal translucency there. Okay. So the nuchal translucency depends upon the CRL. It is increased in fetuses with aneuploidy, structural abnormalities, particularly cardiac and skeletal, and of course, genetic syndromes and infections. But even these, majority of these babies can be normal. So increased NT is not a reason to stop the pregnancy, but it is important to exclude the causes, because you have to look for major structural abnormalities, particularly that of the cardia, and of course, follow up this pregnancy. And even with a nuchal of 6, 7, there is a 30 to 50% chance of having a normal, healthy child. So it's an indication for follow-up. Okay. Now let us look at another example. This is a normal nuchal translucency. The fetus is 66.42 millimeters nuchal, which is normal. But when we did the biochemistry beta HCG was slightly high, Pape was slightly low. And this actually, the risk from 1 in 1400 became 1 in 900. As an obstetrician, I think you should be aware that actually this risk has increased, right? And therefore, you need to go back and look, why did this increase? Because the scan looks completely normal. So most likely the bloods have come back abnormal. So you have a slightly high beta HCG and slightly low PAPI, right? So we are not only looking for chromosomal abnormalities, we're looking for other pregnancy outcomes as well. So again, of course, what is the best way forward in situation, because the risk has increased, you may want to offer her an invasive or cell-free. In this particular case, the couple opted to have an invasive test, right? I mean, I always give options to the parents, and it turned out that it was a Turner syndrome, right? Completely normal fetus. We can land up with these surprises now and then, right? So the biochemistry is done for a reason, because they also can sometimes point us towards some abnormalities. The Western world is not a fool to not do them. Yeah.
Can I interrupt you, Dr. Prathima?
Sure. Yeah.
In Turner syndrome, we do have this, what do you call, increased NT, no? Sometimes because of
Not
that.
all of them, because you see Turner syndrome in your adolescent clinics also. So Turner syndrome again is a spectrum. Turner, the commonest aneuploidy which ends up at miscarriages is also Turner syndrome, but you have women with Turner syndrome who are conceiving now as well, right? So, and you have a spectrum, right? So
cystic hygroma, I was thinking, no? Okay.
Not all of them. Of course, the presence of that will increase the risk, but not all of them will have Turner syndrome, right?
Yeah.
This is, of course, just a freak case, I would say. It's not usual scenario, but what I wanted to highlight is please pay attention when the risk increases in a mother. So first trimester scan plus serum biochemistry is only a screening test and not a diagnostic test. I think we have said this. Now, this is a 33-year-old with just a borderline nuchal translucency there, 2.5 for 74. So it's right up there. And then when we do the bloods, the beta HCG is significantly high, the PAPA is significantly low. The first trimester report was already released saying 1 in 4,000, but when the bloods came back within a week, we had to call them back and say, hey, look, we are sorry, but your risk has actually now become 1 in 35. And this was, of course, the pre-cell-free DNA era. They wanted to do a CVS. We did a CVS and turned out to be normal, right? So then, of course, we follow up this pregnancy for growth and it was 2.4 kilos, okay? Now, high beta HCG and low PAPA, it is very important to look at the growth because these are placental function indicators, okay? And the next one is a very, very interesting. It's an eye-opener for us. So this was a 37-year-old. She had she had the first trimester screening done elsewhere. She already had an NIPT by the time she came to us at 14 weeks, which was a low risk, and fetal fraction was 7.2%, which was okay. So when she came to us, she was referred to us at 20 weeks with these kind of bright white spots. And this is, of course, hepatic calcifications, multiple hepatic calcifications at 20 weeks. Now, this can be associated with not only aneuploidies, growth restriction, and fetal infection as well. So we did discuss with them invasive testing. And of course, it is a dilemma what to do when NIPT is low risk and you have hepatic calcifications, right? So think about infections and aneuploidies as well and growth restriction. The couple opted to do an invasive test, and lo and behold, it turned out that it was trisomy 21. This was very, right 2-3 years into our experience with cell-free DNA, and it was an eye-opener. And subsequently, we, said that, okay, fine. We have to have a good selection of cases where we offer NIPT, and it cannot be randomly done for everybody. And so we follow a certain rule book when they come to us. But of course, because many obstetricians are already doing NIPT even before they reach for the scan, we have these low risk reports, and then we have to spend extra half an hour with the couple explaining to them why we can't depend on the NIPT, particularly done in any and every laboratory nowadays. Now, this is another interesting case. She had EIF in the left ventricle and hypoplastic nasal bone. Both hypoplastic nasal bone, as you know, is an important marker. And of course, presence of two markers also increases the risk. She had an NIPT done earlier at 18 weeks, which had a fetal fraction of 13.2, and that was a high risk. Now, she already had this done before she came to us. Right now, this is where the challenge comes. I mean, if we know that there are two markers and the risk is going to increase significantly, to me, the NIPT was a complete waste of time and money, right? But anyway, that came back as high risk, and we did an invasive test, and that did turn out to be trisomy 21. So we have to think before offering NIPT randomly. Just because we are waiting to see the fetal medicine specialist for the next 3-4 days appointment, it doesn't mean that we just send off the blood for the NIPT. Let us wait if you're going to wait that long, because they might choose. In fact, I've had patients actually call and cancel the NIPT, or just say, why did we do the NIPT when we were going to do the invasive anyway? Because it's just waste of time and money. Okay, now this is a 19-week pregnancy which came to us with early onset growth restriction. Dating was all correct, checked everything, and first trimester was reported low risk. So this was an early onset growth restriction. So anyway, we discussed all the pros and cons, I mean all the possibilities, and the couple opted to do an invasive test, and they were counseled for early onset growth restriction, and follow-up and karyotype was done. So fortunately, this was a non-genetic and she delivered at 32 weeks, a 1.5 kilo baby. And then, of course, baby was doing well subsequently. Another case, increased nuchal translucency, 3.3 there. That's the increased nuchal translucency. And the baby, in addition, had tricuspid regurgitation. There was nasal bone was present. The risk, the blood test was already done, which was 2.8, 0.2, and the risk was more than 1 in 4 possibility of chromosomal abnormalities. They opted for invasive test, and of course that came back as trisomy 21. And importantly, not just the fish, we continued with the karyotype, which showed it was a translocation Down syndrome. Now, when it is a translocation Down syndrome, I already told you that the risk of recurrence is much higher depending upon what translocation, where it is, and whether it is the father or the mother who is a carrier, or sometimes both of them may not be carriers. So the next pregnancy management will be very much dependent on whether it was a translocation Down syndrome. So this is the end of my talk, literally. So we have aneuploidy timelines. The first trimester scan is done at 11 to 14 weeks, second trimester 18 to 24 weeks. You have a first trimester quad screening that you can do along with your first trimester scan, second trimester quad screening from 15, ideally up to 20 weeks, not beyond that. NIPT pretty much can be done at any point of time, but then I don't like NIPT after 20, 21 weeks, because NIPT results takes 2 weeks, and if that comes back as high risk, then again we are stuck. Before 24 weeks if we have to check. So if there are screen positive, screen negative, screen positive, you can have screen positive biochemical marker test, and of course screen positive cell-free DNA test. Then we need to do further testing and possibly invasive testing as well. Now, first trimester screening, of course, is still the best, which has got a high detection rate and a low 5% false positive. If you do only the second trimester quadruple marker, that has got a detection rate of only 75%. An integrated sequential first trimester and second trimester only is also not so great, but cell-free DNA, of course, you can is good with a high detection rate with a low false positive. But at least you must do first trimester scan with the quadruple marker test and the and the anomaly scan. The first trimester combined with an anomaly scan plus minus second trimester quad, you can achieve a really high test. So essentially, all women should have all the options. Definitive test, which has got 100%. If they want that, then it's an invasive test. If they are happy with 99%, others are incidental, you can do cell-free DNA test. You want a 95% detection rate, they must do first trimester combined and second trimester combined. That is second trimester quad with the genetic sonogram. And if you do only the first trimester combined with serum biochemistry, that is a 92%. And if you do only the first trimester screen, so it's easy to remember, 90, 92. And as you go advance in pregnancy, the detection rate gets better and better. But only doing serum screening or only the scan in the second trimester is not a great test to detect chromosomal abnormalities. So we need to be dependent on both aspects of it. So when you find a soft marker, it is important that you look for other markers, you look for anomalies, you look for growth restriction. If you look only for soft markers alone to assess, then it is definitely an inefficient test. The low-risk cell-free DNA contributes the soft marker to be negligible. But again, isolated marker, no invasive testing. But if you have multiple markers with the low-risk cell-free DNA test also, you must offer diagnostic testing. And of course, at this stage, you would be offering amniocentesis for other genetic conditions. Now, further reading, of course, I would suggest Professor Nicolaides and fetalmedicine.org. And it is very simple reading, very simple, easy. He explains things like mathematics. And of course, the dream of inverting the pyramid of care goes on and on and on, not just for aneuploidies, but for anomalies, preeclampsia, growth restriction, gestational diabetes, SPAS, PASA previa, and so on and so on. And this man is relentlessly researching to make the life of the pregnant mother and fetus, most importantly, and of course, the life of obstetricians much better by, analyzing or by researching in the beginning of the pregnancy and looking for things in the beginning rather than towards the end. So in 2025, ideally, we should pledge that no woman should be deprived of screening. Every woman deserves to have a good screening, and no fetus should be terminated without a proper indication. And I can't emphasize this more than this, because, fetuses are precious. Every pregnancy is precious. I don't like this term, precious pregnancy. Every pregnancy is precious. I have not come across a single parent who says my baby is not precious. I think, and we have to treat every single fetus with that respect, and that humility is very, very important. So with that, I would also like to invite you to participate in the unique multiple pregnancy conference that we are doing in Bangalore, with, of course, Professor Nicolaides giving a major contribution online, of course, with Professor Leona Poon and Dr. Austin, who's a maternal specialist, and Surabhi, who's a fetal-maternal specialist, along with our genetics neonatal. So basically, it is an idea to bring the entire, all the people who look after the mother and the fetus in a multiple pregnancy, and to have a discussion, dialogue, and see how best we can improve these outcome for these babies. And of course, the mothers also, because we know mothers also have a lot of morbidities and mortalities in multiple pregnancy. So the idea is to bring all the fraternities together, so we speak to each other. We cannot be disconnected from each other when we look after multiple pregnancy. And of course, there are a lot of workshops and things like that. So I look forward to meeting many of you. You can get all the information from fetalandgynaeimaging.com. So thank you very much for the fabulous time that I had to put in my thoughts.
There are so many questions, so many permutation combinations.
Let's go through each one. I think there are very interesting questions have come up. It was very nice to see them all come up. So of course, in the beginning, Dr. Mitra commented on your graphics, ma'am, that they're very nice. And then
actually, let me tell you one thing, Kirti. I now understand why people want the recordings, because they listen and also they look at the graphics easily. When we are giving the lecture, everybody is speaking so fast, and the graphics were so well, they were highlighting every point. So I think.
And actually, in this presentation, ma'am, Prathima ma'am is always good, but for some reason, I kept thinking she surpassed herself even the last because there are so many nuances which she has put together in one slide, especially towards the end. So I would urge everyone to go back and definitely go through the presentation again, and if nothing else, at least the last 20 minutes. For sure, because each slide has a lot of specific information regarding every small
स्क्रीनशॉट
part.
लेने का मन कर रहा था आपके हर स्लाइड का स्क्रीनशॉट, but the recording is there. Let's ask questions.
Yeah, so ma'am has said SUA I have found in babies always having a low birth weight. So ma'am, what should our guidelines be for when we see SUA, and we can be reassuring to the patient, but what do we tell them about growth monitoring for
I
these
think
people?
we should monitor the growth. I did say in the SUA slide that
Yes,
they should have serial growth scans.
and
Again,
from
not
when?
all of them will have, not all of them will have growth, but growth is easy to monitor. And now the third trimester scan has become almost mandatory, right? So you need to do a scan at 28, 30 weeks and 36 weeks. So I
Yeah.
think 4 scans have become very important. Your first trimester scan, your anomaly scan, your 28, 30-week scan, and your 36-week scan. And that will pretty much cover even for evolving anomalies and all these, unusual growth restrictions and things like that.
Right. So at least 2 more scans then, one between
Yeah, which
28 to
again,
32 weeks, and then
this is what I'm saying,
10
Kirti. This is now becoming routine.
routine
Right.
and
Now it's
32.
become routine because we know that we can find anomalies in the third trimester. In fact, a lot of our work is actually in the third trimester anomalies as well. And in India, actually, we have far more because we have that information now.
So the next one, ma'am, is single finding of ARSA. So isolated ARSA with an NIPT normal and the amniocentesis assuming normal. And at 36 weeks, Dr. Rachita sees some mild IUGR. Is there anything else that we need to take care of?
In isolated ARSA where everything else is normal. No,
Including an amnio. So I'm assuming that at least a karyotype is normal. So no need to worry
No, I
in
don't think
case
so.
of
If
mild.
you just monitor the growth because that
Correct.
is unlikely to be related.
So should echo be advised invariably in EIF when biochemical screening
No.
and rest of anomalies
I'm
normal?
so happy with this question. I'm so happy with this question. EIF is not a cardiac defect. It will not become a cardiac defect, right? EIF is just a marker for Down syndrome. EIF is not an indication for cardiac scan. It is an indication to do a good anomaly scan because you need to look at other markers associated with EIF, right? Of course, basic cardiac scan looking at the 5 planes and 6 planes has become mandatory now. For all your radiologists, sonologists have to look at the 4 chambers, LVOT, RVOT, 3-vessel trachea view, and they have to look at NRSA. So it has become mandatory, right? So EIF, if you find an EIF, please don't refer them for a fetal echo. They need a detailed anomaly scan and assessment of risk for chromosomal abnormalities. That is the right thing to do for EIF. Right? I
And
still get a lot of EIF, do only fetal echo. I said
yeah.
that is completely waste of my time and your time. I will look at the heart anyway. I will look at the heart. I will look at the 4 chambers, LVOT, RVOT, 3-vessel. I will look at the heart beautifully. But please, and I will not charge you for an echo also because I don't think I need to charge you for an echo, but I have to look at the rest of the baby. You have to allow me to look at the rest of the baby because if I find an ARSA, or ARSA, okay, when I'm doing an echo, I will find an ARSA. But if I have an hypoplastic nasal bone or absent nasal bone, the whole EIF, the format changes.
The risk changes completely.
It changes the whole scenario, right? So if you're doing a re-evaluation of the fetus, it's always good to have second, third opinion. In fact, I tell my patients also that even if I see the baby yesterday, I will see the baby again today. Right? Because you may find things, the baby is in a better position, you will see things more. So if they want to go somewhere else and have another opinion, please do. Please, the baby, it's the patient's right. And as an obstetrician, you refer them for a detailed anomaly scan and risk reassessment and not just an echo because an echo is not going to help. AVSD should be picked up on a routine cardiac scan. AVSD, you don't need an echo. Heart scan is a part of an anomaly scan. Right? It is a recommendation now that it is a part of an anomaly scan. So everybody who's doing the anomaly scan must be doing the detailed heart scan as well.
And should the approach differ in cases of a single EIF versus a multiple EIF? Because we see a lot of
nothing. Single, double,
very
this one, right, left, nothing. Just make sure that it is an EIF, that it is an papillary muscle, and it is not on the walls. Because we have had some time ago where referred with EIF, it turned out it was a rhabdomyoma. So rhabdomyoma again changes the scenario. Right?
So EIF, when in doubt, go for a second opinion, but go for a
second opinion.
with
It's
an
good to have a
anomaly.
second opinion. You're only benefiting the baby, benefiting the parents, right? It's okay to have a second opinion. There's nothing wrong in that.
So, ma'am, then the next question is, what is the cutoff for short humerus length?
Less than
short
6
femur length. Less than
Less
50.
than fifth centile as a marker. For skeletal dysplasias, it will be less than 3%, third centile.
Correct. So, for Dr. Rajeshwari asks, 41 years spontaneous conception, double marker is normal. Is doing an NIPT enough?
Okay. What is a double marker? Double marker is a blood test, right? A double marker, when somebody tells me they've done a double marker, it tells me that they've done a 65% detection rate, right? Now, if you have done the NT scan along with the double marker, respect the NT. Call it a combined first trimester scan. When you've done the NT has a much more weightage than a double marker. So you have to say NT plus double marker is a combined test, has given me a 90% detection rate, right? And then I have a 40-year-old, it's got a low risk. You give me the numbers. Is the risk come down from 1 in 50, which is going to be the risk for a 40-year-old? It has come down to 1 in 200, or it has come to 1 in 1,000. If it is 1 in 200, maybe I will say, okay, let us improve this and give her a cell-free DNA also. Or if it's come to 1 in 1,000, I will discuss, do you want to do a cell-free DNA for further reassurance, or you want to leave things alone? But I'll be on a cooler path, not worrying too much about her, right? But I think we cannot call the test as a blood test, because if somebody tells me double marker, I'm only thinking double marker, because double marker has an accuracy of 65% detection, whereas a combined first trimester has got about 85 to 90%. So call it the combined first trimester scan.
Yeah. Actually, these words, no, they're very confusing.
Yes.
So very simple.
No.
USG plus screen combined
first
test.
Combined test. It's a combined test, right? The combined, when you say combined test, I'm, much more alert.
Yeah, there is a question, if combined first test is normal, any additional benefit of doing a quad marker?
Not really. I mean, normal in the
really,
sense you're
yeah,
talking
just
about low
2%,
risk, right? Because, and if you have, I mean, if you are getting another 2 to 3% benefit of that, but I think, yeah, I mean, it's not going to be hugely beneficial.
And ma'am, NT is raised and everything is fine. Like no aneuploidy. Aneuploidy screening is negative. I still would say that a fetal echo is a must if NT is raised.
Yes. If the NT is increased, because we know in euploid fetuses, the chances of finding a cardiac abnormality is higher, right? And also, if the NT is more than 4 millimeters and you have a normal euploid fetus, then it is better to do an earlier scan. You do it at 16, 18 weeks, because what heart you can see at 20 weeks, you can see at 16, 17 weeks also, right? Provided you have a good machine and you have got good skills. And that's how we all learned. We were looking at 22, 20, 20, now 18, now 16. Now we look at hearts at 12, 13 weeks also, right? So we have just gotten better. Machines have gotten better. Skills have gotten better. We need to take advantage of the, appropriate skills that your colleagues have developed.
So in next question is, if there is an absent nasal bone, if the NT is normal, double marker is normal in a 23-year-old, should we go for NIPT or amnio? Again, similar, different permutation combinations.
Yeah, I think you have to discuss with the patient, really, because you don't have anything to say that how did that mother look at, whether the nasal bone is going to be like the mother. I mean, I have people saying, oh, my nose bone was small, but I just tell them that I don't know how you looked when you were in your mother's womb. So I have nothing to compare, right? So, and also remember, the Down syndrome babies also have a nasal bone, but the challenge is there is a delayed ossification of the nasal bone, right? So any delay in the ossification of the nasal bone is a marker for Down syndrome. So you need to discuss with the mother whether, they'll be happy with just doing a 99% test or they want a 100% test. That's just a reassurance thing. Some couples will choose 100%, some couples will be happy by 99. And basically the same answer will not fit everybody. But your choices are limited to only between two. You don't have any more choices.
So the next, I think we have covered for ARSA, what should we do if the first trimester screening is normal? Should we do NIPT?
No, I think for ARSA, it's not enough you do karyotype. In fact, ARSA, I told you there's an association with DiGeorge syndrome also.
Yeah.
So NIPT, in my opinion, is not enough. So if you find ARSA, even if it's isolated, it is better to do a invasive and exclude 22q microdeletion also, because that has got a huge, impact on the family. They've got a lot of psychiatric problems, and they've got a lot of, health issues, the children with DiGeorge syndrome. So it's not okay.
So 22q11 is also significant when ARSA is there. So ARSA
Well,
ideally
it's
offer
not
invasive
significant, I would say. It's not significant, but it has been
fine.
reported, right? And we
I mean,
don't really screen for 22q11 microdeletion. So we may be missing quite a few as well.
Okay. Mild ventriculomegaly at 22 weeks, should we go for amniocentesis, and is termination justified?
No. Mild ventriculomegaly 10 to 11. See, termination is also not justified. The other reason being that you need to know why this mild ventriculomegaly. Is it a brain anomaly, or is it a chromosomal genetic abnormality, or it's an infection? Because mild ventriculomegaly that I'm seeing at 22 weeks and at 28, 30 weeks, it becomes a neuronal migrational disorder. I want to know it, because in the next pregnancy, the same thing will happen again. Again, you'll have mild ventriculomegaly, and at 28 weeks, the baby will be bad. So if you have a baby that has got mild ventriculomegaly, you need to investigate. And if you have an evolving brain anomaly, you need to do further genetic syndrome and exome on that baby. So in the next pregnancy, you can do a CVS in the first trimester and help that couple. Not wait for 28, 30 weeks for the brain to become bad again. So mild ventriculomegaly is definitely not an indication. And now with the rules for the termination of pregnancy being much better, you have that luxury of investigating the fetus and terminating only when you have an absolute indication to
Terminate.
And even before this rule came, and even before neurosonograms came, we followed quite a few babies with ventricular. In fact, one of my fellows, she looked at nearly 400 fetuses with mild ventriculomegaly, and 98% of them were fine neurologically even after that. The ones which were non-progressive and which did not have chromosomal abnormalities and did not have any. So you need to set up a set of investigation. You need to check this fetus regularly and then think. So certainly termination, no. I think we must say we will not terminate without an indication, right? That's very, very important.
I just want to say two of the things that you have said. They're so important. The first question that comes in the mind of the patients is that, like, what is the diagnosis like? And secondly, what are the chances in the next pregnancy?
Again, exactly. And we
So
cannot
as an
answer that
obstetrician,
question.
the onus is on us. We have to go that extra mile. Sometimes people will short circuit and say, ये तो abort करना ही है तो कर दो, and then no advice is
अगले बार
given.
देखेंगे. That is even worse. Because अगले बार, most likely the patient doesn't go back to the same obstetrician. They'll go to somewhere else. And then they say, उन्होंने तो ऐसा बोला था, इन्होंने वैसा बोला था.
They come with the same problem
And
again.
please, 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 obstetricians, document what you tell the patient, because the patients tell us one thing and there is nothing written in the document. So you don't know who is, the patients also twist and turn their words very easily, right? So please don't presume that, you will remember everything. Most of the times, 2 years down the line, you don't remember anything. Write down everything and that's it. Your job is done.
I liked your statement, this also, that even if sometimes, for very minor things, patients will get the termination done because some relative will tell them, ye to kharab hai, bachcha kara lo. They won't go. But we have to make sure that no
who is actually
unnecessary
doing the
termination is done.
Who is actually doing the termination? The obstetrician is doing the termination. The in-laws are not doing the termination. I think you have a right to decline that I will not terminate a normal fetus or a likely normal fetus. And I think I have the
ट्रिपल मार्कर जो कि ऑब्सोलीट है, ट्रिपल मार्कर की स्क्रीनिंग पोस्ट पे एक प्राइमी ने अपनी टर्मिनेशन करा ली थी. मैं पगला गई थी कि प्लीज मत कराओ, बट ऑफ कोर्स बहुत पुरानी बात है, बट
So now we have a scenario which does crop up in practice. First trimester screening, NT was increased, double marker and NIPT was done, which was reported as low risk. Now she has come at level 2 and nuchal fold thickness is increased. What should be done?
Sorry, say that again. Say that again.
NT was increased, ma'am, on first trimester combined. So they went for double marker and NIPT, which both came as low risk. But now she's come for an anomaly scan, and the nuchal fold thickness is still reported as more.
Yes, of course, you have to do an invasive. You should have
Before
done
the
the invasive
waist
in the first
first
place. Right?
yes.
First place itself, because we know that we are not only screening for Down syndrome. For God's sake, I think we should get out of that situation where we think that we are only screening for Down syndrome. We are not screening for Down syndrome only. For every baby with Down syndrome, there is one more baby with some other genetic problem. I tell parents, if I have a room with 100 babies with genetic syndromes, 50 of them are Down syndrome. Agreed. Maybe 20 of them are trisomy 18. Another maybe 5 are trisomy 13. But the remaining 25 are all the other chromosomal abnormalities, genetic abnormalities, right? So for every baby with Down syndrome, you'll have one more baby with something else. So don't think that if there is a high risk for Downs, NIPT high risk for Downs, you will find something else, right? So Down syndrome is just an example. It's just our starting point. Today, the first trimester scan is not known as NT. I mean, I don't even like to call it NT scan. I like to call it the first trimester screen or first trimester scan, because you are looking at so many things in the first trimester, not just.
Yeah, I think we should
You're
correct
looking
that
for anomalies, you're doing preeclampsia, you're doing growth restriction, you're doing, you're doing vasa previa, you're doing so many things are going to come up now, right? And we have to screen for all of those abnormalities in the first trimester itself. So it has to be a first trimester screen. Let us get our terminologies right, and then our thinking process will follow.
So important takeaway for increased nuchal translucency basically is just go for invasive. Same with mild
Yes.
ventriculomegaly. That's a better choice than going for any of the other tests, because we are looking for many more things apart from trisomy 21. Ma'am, what MOM levels should we look for? PAP-A and HCG are significant, and can you tell us slightly more sharp take-home points for the serum markers, PAP-A and beta-HCG particularly?
That's a lecture on its own. But anyway,
Yes.
if you if you have low serum markers, PAP-A particularly less than 0.5 or beta-HCG more than 2 MOMs, so then put them on follow-up growth scans, because these could be indicators for placental dysfunction, apart from aneuploidies. Of course, you sort out the aneuploidies. And of course, if you're doing PLGF, nothing like it. Fantastic. Great marker for preeclampsia. So also a marker for aneuploidy. And if you have again low PLGF less than 0.5, well, because you'll have preeclampsia screening, the most of the labs which are doing PLGF will give you preeclampsia screening results also. So I think all this has to go hand in hand.
So I think we've covered quite a bit. Ma'am, do you want us to go ahead, Mitra ma'am, with some more questions, or
I
do we call
think
it
I
a
think we
day?
should wind
It's
it up now because it's
9:42, yeah,
already
because we're
beyond
already
9:30.
People
yeah.
will be
My
tired of
little one
listening.
is come thrice. Dadi क्या कर रही हो? And I say पढ़ाई कर रहे हैं. Have a look. आओ सबको hello कर दो. Good night कर दो.
Hello.
Okay, good. Yeah, the 9th lesson.
So I thought I'll keep this for the end. So this was basically 1 second. I don't know what I have done again. So yeah, so this is basically on the 9th Tuesday, and I really like this one because it ends with this tale of a South American tribe, which he talks about how the tribals say in the end that we're all creatures in the same forest, and what we take, we must replenish. It's only fair. And so I think it also connected very well with how we think of karma and karma and karmic intent. And it is with ma'am, with both Mitra ma'am and Prathima ma'am also, I've seen how whatever they've learned, they do focus and spend so much energy on teaching, which is also great. So this was my 9th Tuesday with Maury. Ma'am, you're on mute. Huh? So-
Thank you so much. And you know what? Agastya is telling me, दादी ये लगाओ और उन आंटी को बताओ अग्गू आ गया है.
Hi, Agastya.
बोलो
Hi.
अग्गू आ गया. बोलो सब वेट कर रहे हैं तुम्हारी. अब बोलो ना.
Hello.
हाँ ये
Hello.
देख लिया. Thank you so much. I really, I'm so sorry that his parents have gone for a movie, so I have to take care of him, and I don't want to go. But Kirti, you've, taken the question so intelligently, and Dr. Prathima, I'm so glad. Let me give you a little bit of the number game. We crossed 285 people. So that's
We
so
reached
good.
298 or something at one point. We did.
I wish we could have more time. And actually, you know what? Kirti and me had planned that we are going to fire some more questions, but there's simply no time.
I had many more,
I'm going to
but
call
you
you
know,
again.
I
Ah,
think it's
Dr. Mitra, good evening.
good evening.
Romila, how are
I
you?
know. I know.
Hello. Hello, beta. I just wanted to Dr. Prathima, it was an excellent presentation.
Thank you very much, doctor.
Wonderful. I just wanted to just see your second case in which you said ki, when the serum screening was done, the risk was increased, but it was still above the cutoff.
Yeah, it
So-
was still good. It was still a low risk. Yes,
So it's
you're
so
right.
important to see the risk, na? Otherwise,
Yeah,
you just see the
absolutely. You have to
results.
yeah, you
You
should
just
not
see
even
the
use
results
Yeah,
that
yeah.
the screen is negative because the lab also reports screen negative. They just took
Yeah.
the cutoff
No,
of
no,
1
don't
250.
see. If it is 1 in 251, they will say screen negative. 1 in 249,
Yeah,
they
yeah.
will say screen
That's what
positive.
I'm saying. No, that's
As
what I'm saying.
obstetrician,
And
you have to be more aware.
in your second case, it was 1 in 900 something.
900, correct. Yeah,
Yeah,
900.
it was just the maternal age risk. It was increased, and
Correct.
it turned out to be trisomy 21. So it's very
No, it turned
important
out
to
to be
see the
trisomy. It turned out to be Turner syndrome. It's a very rare thing, of
Turner's.
course. Yeah, it turned out to be Turner's. Yeah.
No, it
It's
was
not
trisomy 21, I think.
second one. I think
Second case.
was Turner's, I think, if I remember correctly. I will show you.
Okay. So, Kirti,
Hmm.
shall we say good
I
night?
think yes. I think we can call
A
it.
very,
a night.
very sincere and loving thanks to you.
It was Turner
Dr.
syndrome.
Prathima.
Correct.
Okay.
Yeah.
I wish we had time. आपका गाना सुनवा देते.
नहीं 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 उतना भी नहीं है. I'm just learning
यार
still.
मित्रा
अरे
How
बहुत
can it go?
अच्छा.
5 मिनट में क्या फर्क पड़ता है, सुन लेते हैं गाना.
नहीं.
Augusta
I
will
don't.
also enjoy.
I wanted to highlight that in the slide that in 2024, ma'am also won the Grand Diva Medicos contest, which was held in Goa,
Oh
where
wow.
a lot of doctors from all over the country participate, and it is a very rigorous thing. You have to change costumes multiple times, and
It
you
was
have
fun.
and we heard of ma'am preparing for it with the same intent that she prepares for any conference.
Yeah. She's a
And it
real
was quite
diva.
inspiring, and we could see the pictures, and we urged her to
तो वो
share
मेरे
everything.
फादर का फोन आ रहा है and Augusta
Okay.
is telling me फोन है आपका.
Thank you so much. Thanks so much,
Thank
Kirti.
you.
Well
Good night,
moderated. Thank you so
everybody.
much,
Hello,
Dr.
Thanks
Dr.
a
Mitra.
lot.
Suman. Good evening.
Thank you,
हाँ, हाय
everybody.
प्रतिमा,
Thanks for the
हाय
lovely thoughts.
प्रॉमिला, हाय अगस्त्य,
नमस्ते करो.
नमस्ते.
Very sweet.
Good night.
Good
Good
night.
night.
चलो जी,
Good
गुड
Thank you,
night.
नाइट,
Kirti.
गुड
Thank you,
नाइट.
Dr. Prathima. Thank
Good
you,
night,
everyone.
everybody. Good
Thank
night.
you. Good night.
Okay. Tada.
Bye.
Bye.